only one here, and I'm extremely happy to be serving this community because it's my home. Now, this presentation is going to be on some innovations in sinus surgery. These innovations also apply to brain surgery and spine surgery and several different other kinds. And it's going to be interactive. I have a lot of pictures. I don't have a lot of words on these, but we're going to go over, and I'm going to have to teach you some anatomy about the skull and a little bit about the disease process in order for you to understand why this is so effective or so useful for a surgeon. Next slide, please. And please feel free to stop me and ask me questions in the middle, because this is an anatomy lesson that I know most of you haven't had the primer for, and it's on CT images. So I don't expect you to know everything, but I'm going to try to teach you enough that you will be able to understand why this is so effective. The challenge for a sinus surgeon is to remove the disease without causing injury to the other things that are around it. So if this is a CT scan, on a CT, and this is like you're looking in a mirror. If this was your face, it's like you're looking in the mirror, and this, anything white is bone. So that's the skull up here, and this is the orbital bones, and these are the eyes, and those are muscles in the eye. Anything gray is soft tissue, like the skin up here, and like the brain, and the muscles inside the orbit, and then the eye as well. Now over here, black on a CT scan is going to show up as, air shows up as black. So this is the sinus underneath the eye called the maxillary sinus, and it is a healthy one. It's pretty large, but it's healthy. Compare that to this side, and you'll see this soft tissue mass. It's gray, so it's either soft tissue or fluid, and it's kind of got a hump this way, so you know it's soft tissue, not fluid, because the fluid would have kind of a hump going down. Here are teeth, the upper teeth. You can see the teeth of this upper tooth looks like it's going up into the sinus. Most likely it's covered by a thin layer of bone that's just too small to be seen on this CT scan. Okay. Any questions on that part of the anatomy class? Okay. So here we go. This is the frontal bone. This is the right eye, that's the left eye. This is the septum. It divides the nose into a right and left half. You can see just the beginning of the maxillary sinus, the sinus under the eye. And then here's good images of the teeth. If we go back a little bit further, we can see that the frontal sinus is now getting smaller because we're getting to the back end of it. You can see a little bit more of the maxillary sinus, and then you start seeing there's some important structures that I'll show you later on. I may quiz you on these, so pay attention. So here is something called an inferior turbinate. If you're to look into my nose, the septum divides me to right and left, and the turbinates are bones hanging down on the outside. They're covered with a lining of mucosa. They warm and humidify the air. The lower one is the biggest one. The middle one overlies the openings to the sinus. So here we have a lower one, and it looks normal size here. And this is the middle one. We go a little further back, we'll be able to see where the opening should be. We can't see it just yet. Next slide, please. There are 4 paired sinuses. The maxillary, which is under the eyes, the frontal, which is over the eyes. Ethmoids are between the eyes, and they're like a labyrinth, like a honeycomb. And then in the very back, the sphenoid sinus is in the center of the skull. A few things of importance back here. We noted in front, if we're trying to remove sinus disease from the area up front, we have the brain that we can accidentally get into, or the eye. And back here, of course, the brain surrounds this. Right in this groove here is the carotid artery. It comes up, major artery in the neck, comes up into the skull base, and then it has a curved path, and it goes right next to the sphenoid sinus. On this top part, the back part of the orbit has the optic nerve, and it's going to course backwards or posterior and towards the midline, and it'll run right across the top there. And sometimes there's a nice big indentation where that is. This is one of the nerves it's the second division of the maxillary or the trigeminal nerve, and it supplies sensation to the front of your face. And this nerve here supplies the lacrimal gland. So they're all important structures. Next. And I'll refer back to these whenever we're talking about the surgery. But this is to show you what you might see if you look into the sinus. Here's that inferior turbinate. Remember I talked about that, warms and humidifies the air. And here's inferior turbinate with a polyp. So looks different, looks kind of like a balloon inside the nose that will obstruct the nose. If you can see back here, it's glistening. That's because this polyp has gotten even bigger and it's filling this whole space. Next slide, please. This is the middle turbinate, and this is the healthy side. And you can see there's a nice little line here. In order to get into the maxillary sinus, we'd have to pull this over this way. And then beyond that, there's a little process called uncinate process. It's like a half-open door facing away from us. You have to get behind there and go into the maxillary sinus. So you can't really see that sinus on a normal exam, even if you have the scopes that are flexible like I have, because it's too uncomfortable for the patient to go in there, bend it out, come back, all that. It's too uncomfortable. Now, this is a middle turbinate that's diseased. You can tell it's not happy like that one. And it's got a polyp right there in between the turbinate itself and that maxillary sinus wall. Any questions? Okay. I know I have people in this audience that are not afraid to ask questions or bother me in the middle of a presentation. Next slide. Stimulate. Okay, so remember the sinus that's in the very middle of the skull, the sphenoid side. Here's the outflow tract in the healthy person, and there's an outflow tract clogged by polyps. Now, polyps aren't the only thing that cause trouble in the nose, but it's the easiest to see on a presentation like this. A lot of times you'll have chronic sinusitis, and you can't see anything in the nose because the outflow tracts are obstructed, and the disease is inside the sinuses, and you can just see redness. But that's not easy to show. It's not as dramatic as a polyp. So that's why I'm using that. Yes, sir?
You keep using in the middle of your skull, meaning like at the top, because when you have sinus pressures, here or here, a lot of times there's a pressure that comes across the top of your head.
Generally, if you have pain that runs across the top like this, it's musculoskeletal. It's from the muscles that are underneath the scalp. This sinus is, if you went towards the middle here, went in and down straight to the top. Now, it can give you pain that feels like it's in the back of your head, but it's not as distinct. If your head hurts up here and even hurts to the touch, it's generally not going to be a sinus infection pain. Okay, next slide. So now I'm going to show you the sinuses after surgery, so you can get an idea of what they look like. Here is this is a maxillary sinus, one against underneath the eye, and this is the inside of it, and this is that the opening has been enlarged so that this part right here, this is the orbital wall, and this is also part of the orbital wall. This part right here is that little piece of bone sticking out there. And this opening has been taken from above this inferior turbinate up to there so that it'll never get obstructed again. And as you can see, when you're operating that close to the eye, it's nice to know where you are so that you don't accidentally take bones away from the orbit. Well, what happens if you do take bones away from the orbit? If you just take the bone away, the eye is going to be okay. If you don't recognize that you've taken that bone away and you start taking out substance from in here, the eye is not going to be okay. Now, we haven't used image-guided surgery forever in sinus surgery. Matter of fact, when it first became popular, general sinus surgery was done through the nose with a headlight, and the endpoint was 800 cc's of blood in the suction basin. Well, that's not a very good endpoint for a surgery. That means that I've got to stop because, patient's running out of blood. Some of the other techniques were incisions along the eye. And sometimes you still use these for patients that come up with bad abscesses in the ethmoid sinuses or in the frontal sinus that start to push the eye out. And you have to relieve that abscess. You may not be able to do it well enough from inside. Frontal sinus surgery, a lot of times they use a transcranial flap, and they would elevate this all the way down, and then outline the frontal sinus using what they call a 6-foot penny Caldwell. You tape a penny onto the patient's forehead, and you take an X-ray of the sinus from 6 feet away, and that penny is when you can compare that penny to the X-ray, and the penny's the same size on the X-ray, then you know that sinus is the same size. So you cut out the sinus and you outline that on the patient's skull, and then you drill and you hope that you got it aligned properly. I've done this procedure and it was very effective, but yeah. I don't need to say anything more. I've done that, and I might still have to do it for some procedures, but now I do it mostly for trauma. With image guidance, you can map out where that is, but if I have to do that particular procedure again, I will use a balloon sinuplasty because I can put the balloon up into the sinus and outline that sinus, and I'll show you an example of that later. But after we got to the advances of endoscopy, the surgeons were able to go in and look at the anatomy and then the CT scan. So we're building on advances that have happened from the time we started doing surgeries. We get CT scans and we're able to study the anatomy and say, oh, so that's why when we went in there blind, sometimes we injure the eye. When I do sinus surgery, I have to talk about eye injuries. This is not very common anymore, but it happened not infrequently in the past. We were doing blind surgery. I never did those kind where you just had a headlight and a speculum and were digging things out of the nose. Luckily for me, I think that would have been unpleasant surgery. So now, without image guidance, we understand the anatomy, and this sinus is easy to find, and the anterior and posterior ethmoids are easy to find. Sphenoid can be hard to find, but not usually. Once you find it, you can find the skull base and then clean from back to forward. This is what I do all the time. But the CT scan can show you things that are important, like, well, look, the skull base drops down about 10 centimeters here and comes back up. So if I'm operating here and I go to the side, normally you're thinking that's safe territory, but in this case, you don't want to take away those bones because you'll be entering into the brain. Normally in sinus surgery, it's pretty easy to see these landmarks, and so you don't make those errors. Go to the next slide, please. Now here's just another view, and it's a little bit further back. This is that same maxillary sinus, and we're looking up into those ethmoid sinuses between the eyes. And so you can see how it looks kind of like a honeycomb. You don't have to take all the bone away, you just take enough so that these will crack. And just to refresh, this is the frontal sinus, the back part of it where it's kind of getting smaller. That's an outflow tract. Here's the maxillary sinus, and here's some of the ethmoids. Next. And then, once again, a slightly different view looking higher up. This is the opening into the maxillary sinus over here, the one under the eye. This is ethmoid. That is the skull base right there. You see how wide it is compared to the pink lining of the rest of it? That's one of the signs I look for when I'm doing a standard sinus surgery that doesn't have anything obscuring my view or any complications. I find that, and then I clean up. The ethmoid roof starts low and comes up high to the frontal sinus, and so once you've found that, you feel pretty comfortable. Next. So now let's talk about the setup. How do we translate? And the image guidance is, I have a device on my patient, and they have a CT scan that was taken with a particular protocol, so that when I put my instruments into the nose, it shows me on the CT scan where we are. Now, it can have a little bit of error, there's a margin of error, a couple of millimeters. That's why you can't just take one of these machines and start doing sinus surgery on your own. You have to know what you're doing before you use it. It's a tool to help us in special cases. Now, let's just point out a couple of things here. I have permission from this patient to show this slide. This is the headset that we put on the patient after they're asleep. And this little wire connects it to the machine that you'll see in a little bit that shows the images. This is actually the balloon catheter that I'm introducing. And remember, I told you that that red line will outline the frontal sinus. Well, that's the outline of this patient's frontal sinus. The instrumentation that we use is a little bit different than that, but when I put this on, and I touch my little registration probe right there, the machine clicks, I hit it over here, it says we're ready, and then I just outline the face with it like I'm doing now, down across the nose, across the face. And this little device over here is an electromagnet, and it communicates with the instruments that also have these little wires on it, and it uses a little bit of physics and geometry to tell the CT scan where the tip of that instrument is inside the patient's cranium. So it's very handy. You know, we go in, we're working, and say, okay, I want to verify that this next step, which would be either sinus or skull base, is going to be sinus. Let's go to the next slide. This is the view you get from the surgeon's point of view. And I had some pictures taken while I was operating by one of the representatives that managed this for us. And so you're looking at this from the same view I have, except I also have a patient view in front of me. That's the surgery happening on the television screen that I use the endoscope to see. It's magnified, much larger than I could see if I was looking through the endoscope with my eye. And this shows me where the tip of this instrument is, and it's a little unclear here, but these two cross marks show me how far back we are on this one. So that's a side view or sagittal. It shows me how far I am left and right, and that's this one here. And then that's the view that I showed you before. It looks like we're looking at the face. And then on this cut, it slices through from top to bottom, and it shows me the anatomy from that view. And so we're right at the sphenoid sinus, and we're going to be taking some stuff out. And I specifically asked for a meal that didn't resemble any of the things I'm doing. But this is going to be real sinus surgery on the next slide. Go ahead. Okay, now this is where you use the parallel. So I'm using my endoscope to see, and I've got these long, skinny instruments, and I'm pulling this stuff out of this sinus. Okay, go to the next slide. And you'll notice that this isn't moving. Even though it was a rep for the instrumentation that I was trying to show off, he didn't capture anything where I had one of the instruments going into the sinus, and so that you could see this changing. So my apologies on that. Go ahead and start that one. So it took quite a while to get all this cleaned out. So I did a first one and then a middle one here, and I'm using that suction to kind of get it out of there, and my forceps to remove it. This is just all disease. Next one. All disease mucosa. And then finally it came out, and then it fell down here. Go ahead. And I reach back in, and that's in the nasopharynx. and I reach in and get it out. Okay, that just kind of gives you an idea of what we're doing. I didn't do a lot of the other stuff because it's hard to follow along. But that shows you, gave you an idea of how I can help correlate landmarks. And now, other question, I know there's a lot of talk. Yes?
Jeff, once you do this procedure on an individual, are you telling us that we're completely
Asleep.
No.
That's what most people ask.
I hope so. No, are we clear from sinus to where we will get sinus infections again, or is this just?
That's a very good question. I can't prevent you from getting an infection. As a matter of fact, if you have chronic sinusitis, the mucosa may never go back to absolutely normal looking because there's a lot of other factors that involve. What the sinus surgery is designed to do is to make it so that if you get an allergy, inflammation, or a cold, that the swelling that results from that inflammation doesn't close off the sinus opening so that the sinus can self-clean like it's supposed to do. So in most cases, if you have recurrent sinusitis where you get a sinus infection, they give you an antibiotic, you get better and you're better until 3 months later you get another one, and you're getting too many of them in the year, that's the easiest to cure, and they heal the fastest afterward because in between cases they're normal. So I go in there, I open the ones that from symptoms and from my exams appear to be the problematic sinuses, and those patients do well because when they get the swelling of the inside of your nose that you get from allergies or from a cold, then their mucosa swells but it doesn't obstruct. And the obstruction is what leads to the sinusitis. And that's why if you go to the doctor, if you've had nasal congestion for 3 days and it's really bad, you go to the doctor and they look in your nose and they see, well, clear mucus, but lots of congestion. It's most likely a viral problem. It's not most likely a bacterial sinusitis. And so you get treated symptomatically. So, some nose sprays to help open things up, something to make you feel better, but not necessarily an antibiotic. If it lasts longer than 10 days, that's a normal course for a virus. And if you're not better or if you're worse, then that's when we start thinking more in terms of a sinusitis. Now I can look in there with my scope and see, oh yeah, there's real frank pus draining out of the sinuses, but the usual doc doesn't have that advantage, and most people certainly don't need it when you go in with your first 5 days of congestion. Now, on the other hand, I do have patients that have been having recurrent sinus infections again and again, and when they come in, they are having a sinus infection. Well, they probably have something else going on, like obstruction, or maybe they have chronic sinusitis that never actually resolves. And so in those patients, they get better, but not completely, but enough to go back to work because you got to make a living, or you got to take care of your kids, or you got to do whatever. And so you suffer along, and then it gets bad enough where you have to go in and get, yes, you have an infection. So what I showed you on the first slide, and that one too, is chronic sinusitis. That person isn't going to get better with antibiotics because it's physically obstructed, and there's just no, you can't clear it out. Okay, did that answer
Yes,
your
sir.
question?
Thank you, Jeff.
Yes, ma'am.
So in other words, if you have surgery, it's got to be chronic sinusitis to have surgery, or?
You can have surgery for recurrent sinusitis or chronic sinusitis. And the cutoff for recurrent is about 4 episodes a year. The cutoff for, chronic sinusitis is defined if you have it for 4 months or more.
And is this done by laser or just whatever you use there?
I'm sorry, say
Is
that.
this could be done by laser or?
Not by laser. It's mostly small hand instruments, and then this powered instrument called a microdebrider that has a suction. It pulls in, like for instance, polyps, and then has rotating teeth that cut it, so it like eats it up a little bit at a time. Okay, maybe I didn't completely answer your question, but if you, I just want to make clear, if I do the sinus surgery and you have recurrent sinusitis, you're likely to have far less infections. If you have chronic sinusitis, you'll probably have far less, most likely you'll have far less infections, but it'll probably still be higher than the normal person. I don't get a sinus infection every year. Some people get one once a year. Some people get a couple a year. That's troublesome when you're up to 4 a year. It's interfering with your ability to do daily, and the balance of, the risk of surgery balances in favor of surgery as opposed to medication for a lot of people. Yes, ma'am.
What's the recovery period?
Well, it's variable. If you have recurrent acute sinusitis, those patients, they heal pretty quick, and it's first week post-op. At first, I tell people to plan to take a week off, but if they feel like doing anything except for weightlifting, then they can do it during that week. But plan for that week. The second week after this, the first week after surgery, I go back in and I suction some of this stuff out to keep it clean. And I plan on having 3 of those weekly visits until they're better. If you have chronic sinusitis, we're going to have 5, maybe 6. We may have to go in 6 months later and do some revision surgery in some areas because the disease was so bad that we're not able to eradicate it, or there's scarring. But generally, about a week, 1 week, a follow-up every week to 2 weeks.
How long does it take? How long for the procedure?
Well, a lot of the cases I've been doing here also involve straightening the septum and doing every sinus. So it's about 3 hours for that. But I can go in and do an isolated one in 45 minutes,
So
which I
if
probably won't use it.
So if I have to go back every week, how long will those take?
Those are about 30 minutes. Yeah, not 3 hours. I'd wear me out. Okay, let's go to the next one. All right, so you asked, why would you use image guidance for sinus surgery? Number one would be in a revision case where somebody's already gone in and done surgery and the normal landmarks are absent. So I use landmarks to help me stay out of the eye and out of the brain. Or when you have polyps that are so bad that they've distorted the anatomy. Sometimes polyps will erode the bones and destroy them, so you don't have those landmarks to look at. When the disease abuts or is real close to a risky anatomic variation. So in that CT scan where I showed you where the skull base is coming across and then it dips down, that's risky anatomic variation. When there's disease right up against that I have to clean out, well, the insurance company says it's okay to use it. And then special cases, like the one you're about to see. Are there any questions? Do you understand? Okay, go ahead.
Well, that's probably not related to it, but I think it is. I've recently been having a toothache, and I went to the dentist. Can't find any cavities, can't find any fillings falling out or anything. Took an x-ray, said that I had a mass of just an infection. So he put me on a penicillin regimen, and hopefully that will take care of it. But is that part of the sinus will affect your teeth?
Well, I think we're going to see whenever the next sinus CT comes by that shows those teeth. I'll show you. But the upper teeth are right next to the sinus, and if you get an abscess in an upper tooth, it can cause a sinus infection, or a sinus infection can mimic a toothache.
Right.
And so there's where we're oftentimes caught between figuring out if it's a sinus infection or a toothache, and I have an advantage there because I started out as a dentist, and so although I don't have all the tools that a dentist have, I do have that understanding a little bit better than most ENT surgeons, and then a better understanding of sinuses than most dentists. So I have a little bit of advantage there, but a lot of times that'll cause a diagnostic conundrum. Okay, next case. This next case is a trauma case, and it occurred in Afghanistan, and it was a Special Forces Australian Special Forces operator who was injured while he was training on some enemy weaponry, and so it's an RPG holding it right here, but the grenade blew up in the tube instead of out there, and so it passed some shrapnel through his face, and he would have been stabilized in a hospital that looked like this. This is two cases going on at one time. This is in Iraq. That's my case finishing up, and that's a new other case they brought in. And he was stabilized there and then flown to Landstuhl where I was working. That's a Landstuhl Regional Medical Center in Germany. Next slide. I have stopped. So here you can see the facial injury, and the shrapnel went in here and went across the nose. Go ahead. And those little blue things are shields in the cornea. Next. Here are the CT images. Here's the destruction of the bone a little bit lower in the maxillary sinus. And this is one piece of shrapnel. So you can see it's, but at different places in the imagery. So that's inside the nose. This is going into the right orbit. You can see it into the right orbit there. Go ahead and advance it. So this is a different view. This is that slice that goes from top to bottom. And you can see that another part of that fragment is at the top and the very back of the orbit. Here it's right on top of the optic nerve. And there you see it going into the brain. And then if you follow it up even higher, it's behind the right orbit and up into the brain. So this would be a case where you really want to know where you are because the anatomy has been distorted. Okay? So we use image guidance on this. Now some other advances that we have, the hospitals can do this here, and I don't routinely do it for other things, but this is a 3D reconstruction. So it shows the entry wound on the nose on this side, and it shows the part of the shrapnel up here. Now, I want you to look at the outline of this. Here's the part, it's like towards the tip, and then it comes out like this and goes down like that. So it kind of looks like my hand if I held it up like that from here to there. So this part's sticking into the brain. Next. And this is from above. That's the anterior cranial fossa. This is the ethmoid sinuses. So it's real close to where I normally work. And then that's the shrapnel coming out. And the carotid artery's right here, dodge that. And it's a fairly safe area if you're going to have a piece of shrapnel, go into your skull. So these are just all different views. Next. So the two options here were a standard neurosurgical approach, where you make an incision across, scalp down here, scalp down there, take bone off from the forehead, lay it off on the side, elevate the brain all the way back, enlarge that hole, and bring that piece of metal out through the brain. Well, the problem with that, I'll go ahead and go to the next. The pros for that is it's a traditional approach with a long history of success, and you have direct access to the cranial vessels if there's a bleed. That part where the piece of shrapnel was, not a whole lot of big vessels there, so I felt like that was not such a risk. The cons are that you create a larger skull-base defect than he already has because the biggest part of that shrapnel is still in the eye and in the nose. And pulling that piece of fragment up into the skull through the orbit might cause blindness because you could see out of that eye. I mean, he didn't have a serious brain injury, that would make, he had a headache, but he didn't have serious debilitation from the injury. And then just taking off your skull has its own morbidities. And you've got a long, big, ugly scar. Next. So the endoscopic approach with image guidance was I use an endoscope to go in through the multiple holes that I already have, clean it up, enlarge that opening in the nose where we don't have to have all those bones to protect ourselves, and then loosen that fragment up and withdraw it so that gently, as I mentioned here, and then repair the skull base defect from underneath with using the bone that's already been traumatized. So we just put it up against there, put some mucosa up against there. I use one of those inferior turbinates to flay it open and put it up there, seal it with this special stuff, and then pack. So next. So the pros for that is it avoids a craniotomy, the skull defect is smaller, and the chance of causing blindness I thought was less because we didn't have to drag that shrapnel up through the orbit. The big con for this is that if I cause bleeding, we'd have to do emergent craniotomy, which is not as optimal as a well-organized and calm craniotomy, let's just say. The other con is that, well, I'm pulling this backwards. It could have little spurs on it. I can cause blindness this way too. So you can cause blindness either way. Go ahead. And here's a fragment. This is the part that was sticking up into the skull, and that's the part that's in the orbit. And I could see probably this much of it in the nose. Next. Yes.
How big was that?
Let me see. Let's see if we. I'd say it's this big.
Wow.
Okay. Next. So I did it that way. I used the image guidance to help confirm the anatomy because it was really distorted. You have a big piece of metal in the middle of things, and normally I go in there and it's like walking through my house. I open the door and there's the middle turbinate. I move the middle turbinate out of the way and I walk back and there's that uncinate. I pull it back and take it off and right there is a bedroom. I open the door of the bedroom wider and we go to the next. I go to the hall. I just follow this pathway just like the great speakers of Rome. They imagine a home and each part of the home is a part of their speech. Well, surgery is the same way. You go from known to unknown, and that's how you keep safe. But when you go in there and it's blasted, you don't have much known. So it was very handy. Took the shrapnel out without causing any loss of vision, no bleeding. And then the defect, and it's kind of hard to see here, but this is dura. I'm outlining. This is just bone and blood, and this is the thick lining of the brain that protects it. It doesn't just sit on the bone. It's like in a protective sac, and that's called dura, and it's right here. And there was no CSF fluid leaking through there, so that made it easier. And we just packed bone into there and put a Tecile, which is a special glue, and then put the Maricel packing, which is a removable packing. So that is an extreme example of where image guidance is helpful. Luckily for most of us, we don't need that extreme, and I just use it for moderate difficulty. But it's super helpful for things like this. Go ahead. And it gives a surgeon confidence in areas when things are not as clear, and that's what you really want. So, what did I do with the facial defect? Next slide. That'll be another lunch. So, we're going to talk later at some point about balloon sinuplasty. I think it's fantastic. Facial reconstruction for trauma and tumors, just because I think it's interesting. And then, if anybody's interested in dentistry and Afghanistan. Questions? Did I freak you out?
Since I was one of the patients pictured in there, and you did a fair number of things on me at one time, if anyone is facing that decision and would like to ask me about what my experiences were, I'd be happy to tell you. In short, I would do it again at the drop of a hat.
Now, I do have patients, I have a patient that just told me, some people, like, I feel great, this is the best I've ever felt. And this one guy said, man, I tell people, unless you really need it, don't do it. That's really how it should be for most surgery. You don't want to have surgery just because, well, it seems cool. You gotta really need it. Because the post-op can be pretty difficult, especially for people with chronic disease. Yes, ma'am.
I had an injury just almost like that, but it wasn't from shrapnel, it was from a drunk.
Oh, yeah.
And,
A motor vehicle accident?
yes, and it just took my nose off and it went down into my eyes and got to right here. So I know what he went through. But I had 5 construction surgeries, and I've had about 5 sinus surgeries because I got MRSA in my nose, and now my the sternum or whatever it is,
The septum.
it's got a hole in it. The doctor said it was about the big as his thumb, and I'm fixing to have to go into another surgery.
To repair that?
No, they won't do that because there's so much scar tissue.
Right.
In there.
Well,
They said they couldn't do anything.
a hole in the septum is one of the complications of septoplasty surgery, and if it's a big one and it's kind of towards the back, it doesn't cause any problems. And if it's small and anywhere else in the septum, it won't cause a problem. But if it's medium size and up front, then it causes crusting and whistling, and patients are disturbed by that. So in that case, you need to have it repaired. For trauma cases, it's much more likely to have a perforation like that because of the devitalization of the tissue. It gets injured on both sides. Yes, sir.
I have one question. People in South Texas, they always complain about sinus infections and allergies and all that. Is that combined together, or is that can create from allergies and all that? Can that create a sinus infection?
Yes. The allergy, when you have an allergy to something, the lining of your nose swells up much more than it normally is, and if the openings to the sinuses are small, it can close them off. Well, normally we get over that in a couple of days, or we get some medicine and opens them back up, or the hole is big enough so that even though it's swollen, it'll still drain out. But if the hole is too small, or if there's some other bony anatomy that gets in the way that prevents it from being as large as it should be, then whenever it gets trapped in there, that mucus, the inside of our nose has got bacteria in it all the time that doesn't cause any problem. But if you get trapped mucus and it starts growing, that's when you get the sinus infection. And that's why we wait 10 days before we just say you've got a sinus infection instead of getting injection. Yes, sir.
One dumb question.
Yes.
I understand that when you sleep on one side, you only breathe through one nostril.
Okay.
And I did some research on the computer and said that 90% of people always breathe only with one nostril. Is that true?
No.
No?
Normally, if you have a normal functioning nose, the turbinates, can you go back to like the very first image of a turbinate, like at the very beginning? Keep going, keep going, keep going. Okay, stop. Go back down. So this turbinate is normal size, and you've got plenty of air around there. There's a nasal cycle where this turbinate swells up and the other turbinate is small, and so it does most of the work of warming, humidifying the air, and then about 6 hours later it changes over. Well, even when that's swollen, if you have good nasal anatomy, or kind of the norm, you should be able to breathe through both sides. If you have a septal deviation, if the septum is not straight up and down like this one appears to be, but leans over this way, then there's not as much room for this to swell, and oftentimes not as much air goes through here, so the other side does more of the work of warming and humidifying air, so it has to increase its surface volume. Surface area, so that it can do more warming and humidifying. And so slowly over time, you'll get obstruction. When you go to bed and you lay on one side, this is a low pressure system. It's mostly veins, and so it tends to pool blood. So if you lay on that side, blood will pool on that side. If you have a normal functioning nose, generally you're still going to have room to breathe. But if you roll over, it may pool to the other side as well. But normally you should be able to breathe. Now, if you have allergies, it causes greater inflammation so that you have less room for that extra blood, so it can obstruct you. If you have a septal perforation, a deviation, then you can't breathe through one side very well at all anyways. If you lay on the side that's a good side and it swells up, you may not be able to breathe at
That's
all.
nothing to be concerned about.
No.
Okay.
I wouldn't worry about it unless you feel like you can't breathe through your nose bad enough that you want something done about it. Yes, ma'am.
When you have congestion, is it helpful or harmful to irrigate with like a neti pot or something like that?
It's helpful, especially around here. A lot of allergens. It just helps clean things, helps thin out the mucus. After surgery, I have people do it 4 times a day until I think that they're in the safe zone where they may only need to do it once a day. Any other questions? All right, hope you enjoyed the presentation.